Greetings from San Diego, California. My name is Brad Monk. I'm a gynecologic oncologist from the University of Arizona Cancer Center, and I am here at the first Energy Oncology meeting. Energy, NSABP, R, RTOG, G, GOG. We are now together as one family, Energy Oncology. And I'm here for Best of the Day with my good friend, Bob Berger. Bob, welcome.
Well, thank you very much, Dr. Monk, Brad.
Thank you.
It's a wonderful opportunity, as always.
My pleasure. As you may know, Dr. Berger is professor and director of clinical research within the Division of Gynecologic Oncology at the University of Pennsylvania. What I'd like to do is to begin a little bit about the biology of ovarian cancer. We live in a world where personalized oncology is what everybody wants to hear about. And I think that we all recognize that high-grade serous tumors in particular are a disease of genetic instability. But I think there are some biomarkers. Tell us about biomarkers in gynecologic oncology generally, but really ovarian cancer.
Well, there are biomarkers and then there are mechanisms. And so we're trying to identify cohesive mechanisms involved in the progression of disease that may subject themselves to targets of therapy. So the ones that come to mind that are classic and unified in high-grade serous cancers, which represent the majority of patients with disease and also contribute to the highest degree of morbidity and mortality for ovarian cancer, relate to homologous recombination deficiency, which is actually a process that may be involved in the carcinogenesis pathway. But when these tumors develop and they have evidence of inability to repair double-stranded DNA breaks, which are common to these highly genetically unstable tumors, there is a way to take advantage of that. And that is through the use of PARP inhibition, which essentially allows us to essentially set up these cells for failure. Because if we accumulate single-stranded DNA breaks through the use of PARP inhibitors, that ultimately allows cells to accumulate double-stranded DNA breaks that can't be repaired in cells that have evidence of homologous recombination deficiency, then those cells will undergo programmed cell death.
And I think that's very educational. And the hallmark of homologous recombination defects are not exclusively, but a lot BRCA1 and 2 dysfunction.
Well, this is where this was discovered, and so we're now taking advantage of our knowledge of in women who have germline mutations in the BRCA1 and BRCA2 genes that are involved in the pathway.
And how often does that happen in high-grade serous cancers?
Well, the evidence right now is that we have about 15% of women probably who have epithelial ovarian cancer. And
in Ashkenazi Jew it's higher, and I remember even in Australia, which may be different than the way they are in Arizona or Pennsylvania, it was 22%.
That's right.
So it's a lot.
But it's also important to understand that perhaps up to 50% or more patients harbor defects that are independent of having BRCA germline alterations, and they can be sporadic events in patients where you have disruption of the BRCA genes in a somatic sense. There are other defects. Epigenetic silencing. You can have other genes in the HR pathway that are also affected.
So would it be safe to say that every patient with a high-grade serous tumor should have a BRCA test regardless of family history?
Not just the BRCA testing, but perhaps other tests that are in development once they're validated as evidence of mechanism.
Right. And I think that's a good teaching point and learning process. It really is common for me to see a patient in consultation, and she doesn't know what type of ovarian cancer she has. Could be an endometrioid, clear cell mucinous, low-grade serous, or the typical high-grade serous. And if it is a high-grade serous, she's never heard of BRCA1 and 2 testing. And Angelina, very common, we need to fix that. So that's one of our first points. Now, you talked about PARP inhibition. Tell us about some of the experience with olaparib, which was really the first molecule that we got involved with. Tell us about where did it come from?
Well, this is the most commonly, the most well studied of the PARP inhibitors in ovarian cancer. So it really did get a head start. In fact, there were some proof of principle trials with the drug olaparib that have led to phase 3 development. And so we have, I think, the most key trial, landmark trial in terms of proof of principle was a maintenance trial conducted by Dr. Jonathan Letterman, Study 19, where women with platinum-sensitive disease, platinum-sensitive recurrent disease, who were responding to or had responded completely to second-line or third-line platinum-based therapy were randomly assigned to olaparib versus placebo as a maintenance strategy.
And that's great. It made sense. Unselected patients, high-grade serous.
These were all patients with high-grade serous
and what did that
cancers,
show?
And that showed a significant improvement in progression-free survival. In fact, it was a result that no one had really seen for a while with any therapy, let alone a targeted.
So
agent.
hazard ratio, what, 0.35?
The hazard ratio, correct, and so that's a 65%
Unbelievable
improvement in progression-free survival.
So the first thing is that was not biomarker driven, but there was a phenotype that they had selected out because these patients had responded many times, at least twice, to platinum. Olaparib maintenance or not, hazard ratio of 0.35. But if you restricted it to the germline mutation carriers.
So if you restricted it to those patients, and this was an update presented at ASCO 2013, then the hazard ratio was twice as good.
Wow.
So it was 0.18, which...
So unheard of per progression.
Correct. And then when they looked at that subset, they also had a 26% improvement in overall survival, which was statistically significant. So it's a post hoc.
Yeah, but it's great.
Analysis.
And I would argue that the biomarker concept in ovarian cancer has been validated. So the biomarker is first a phenotype and then a response, and now a mutation in BRCA1 and 2 with a hazard ratio of 0.18. So that has been an explosion now that pharmaceutical companies have realized that maybe there's a registration strategy and maybe even a survival advantage, which we haven't shown with our anti-angiogenesis molecules. So tell us now what the GOG is, or the energy. I said GOG, the GOG doesn't exist anymore. What energy oncology is doing with olaparib.
Well, olaparib is being studied now as a phase 3 trial as an extension of the phase 2 randomized trial. So there's a study that is exactly the same patient population, but restricted to BRCA germline mutation carriers. And this is, it's a registration strategy. Once a drug is approved, it might be applied to all high-grade serous cancers, but I can't really say that.
Right.
And
that's called Solo 2.
So that's Solo 2.
That's just like Study 19
exactly.
was published in the New England Journal.
But why limit therapy to second or third line when you can potentially make it a more significant impact on overall outcome by applying this in the frontline setting? And that's really the focus of the other trial, which is Solo 1, which is a maintenance trial in the frontline setting in BRCA germline mutation carriers. And NRG or GOG is participating in this. So there's an offshoot of GOG which is participating in the frontline trial.
And we're still learning the lingo, you can hear it. So GOG now is GOG Partners, which is a pharmaceutical alliance or allegiance or partners study. So this actually is a GOG Partners trial, 3004, frontline maintenance with olaparib.
And these are highly valuable, scientifically valuable trials that the GOG partners with industry.
So we got two groups, Energy Oncology, which is CTEP funded, and GOG Partners, which is not. It's amazing. And so I think if you're going to put your patient on that trial, because it requires germline mutation carriers, you got to test your patient. And you told me that I should test everyone.
And that's been the standard practice.
So, but I think a key exclusionary from this Solo 1, or what the GOG Partners calls 3004, is that you can't have bevacizumab. So you have written that probably you shouldn't start bevacizumab until cycle 2 or maybe even cycle 3. So in my practice, I use that time to test the patient for BRCA germline mutation, and if they're not positive, then I go ahead and give them Q3 week with Bev, and we'll talk about that more in another discussion with Professor Beer. But if they are mutation carrier positive, then I give them weekly paclitaxel Q3 week carboplatin, enroll them in 3004. So personally, I can separate out when to use Bev in non-germline mutation carriers and when to use weekly, well, when they're germline mutation carriers, so that I can enroll them in 3004. Critique that. Tell me what you think of that.
I think it's a great strategy. I think that the patients that have the biomarker
right.
Are uniquely positioned to enter a frontline maintenance trial.
And we've shown that Q3 week with Bev has the same progression-free survival as weekly without Bev, although not directly in a comparison, but in a randomized trial where it was a stratification factor. 14 months is exactly the same, and that was presented in Europe. So we can discuss that more in another interview. But we have a lot of work to do to integrate Bev, integrate weekly, and now integrate PARP in frontline. So we got a lot of work, and I think this is beginning to create a paradigm.
And when you have a trial running in frontline maintenance and a trial running in potentially second-line maintenance, but those patients would have been excluded from the second-line trial, it's not clear, again, what's the correct disease setting? Does it matter?
Sequencing.
PARP after PARP? Who knows?
So that patient that had Q3 week with Bev, assuming she does well and develops a platinum-sensitive recurrence and responds again, then she can go on Solo 2. And that PARP inhibitor patient who ultimately gets treated frontline with weekly goes on the Solo 1 maintenance. If and when she recurs, she can have Bev, a la Aurelia or Oceans. So it's an integration of a number of
and we know in ovarian cancer right now that we have so many active regimens that have a cumulative effect on overall outcome.
Exactly.
And it may not be important exactly when.
And you've argued hard to keep, that long-term tumor control with a good quality of life is what's important, and it's a serial agent, and it's an eye-on-the-ball sort of concept.
But we want to cure these patients.
Right.
And I think with a PARP inhibitor added to frontline therapy and maintenance, we may have a potential
That's right.
to increase the cure fraction.
We'll see. That's right. Now, that's a great elaborate. We told the whole development story. There are other PARP inhibitors. So what are the differences between these PARP inhibitors? We're going to run through a few of them.
Well, I don't think that there's really any head-to-head chemistry that we can really determine. They all have a common mechanism of action, and really it's just the name at this point that differentiates all these agents, but they're moving ahead at full steam into phase 3 trials.
Yeah, I hear people talk about potency, but potency really is a matter of dose.
I think for now that's what we can say.
Okay. So I guess the next one, niraparib. So niraparib was a Merck drug. It was bought by a company called Tesaro. Tell us about the niraparib program.
Well, the niraparib program is really following some of the footsteps for olaparib. In fact, right now there's a trial enrolling patients with platinum-sensitive disease in a maintenance strategy, a la protocol 19, but includes patients with all high-grade serous tumors, and is evaluating BRCA germline mutation carriers as well as BRCA somatic alteration carriers in the same trial.
So the difference between Solo 2 and the Tesaro trial, it's called the NOVA trial, is that the NOVA trial, as it is currently open, will take non-mutation.
Right, not only mutated germline, but also somatic.
And then there's a third trial in that same space, I mean, so you publish a trial in the
Right.
New England Journal, that means 3 other randomized trials are going to try to publish a phase 2 in the New England Journal, and then you got 3 phase 3s from 3 different companies.
Exactly.
So what's the third agent?
The third agent is rucaparib, which is essentially in the same family of drugs, and there are actually now 2 trials. One is a placebo control, is an open label phase 2 trial enrolling patients with all high-grade serous cancers, regardless of whether they are from patients with BRCA germline alterations or harbor somatic mutations in the BRCA genes. And so there's very, very important translational research to try to validate
Right.
Whether we can actually predict up front which patients have this BRCA phenotype or HRD phenotype. So that's actively accruing, and in fact, it's near to closure. And we have another trial with rucaparib that's on its heels, which is a phase 3 randomized control trial. It's placebo-controlled in platinum-sensitive recurrent disease, all high-grade serous.
So this is great.
But that's not a maintenance trial. So I think that it's a slightly different paradigm.
But if you have a patient with platinum-sensitive recurrent ovarian cancer who's responding, think PARP, and you got 3 options: solo 2, got to have germline mutation carriers, okay? Nova, the Tesaro drug, niraparib, and now Ariel 3, as it's called, which is rucaparib. So the take-home message: PARP is here. And I think it's we as clinicians owe ourselves to understand these clinical trials and ultimately to search them out. And I would offer you and our listeners, I know both of us have these trials open to try to get these PARP inhibitors into our patients. That was an excellent summary. So I guess there are other biomarkers. The other biomarker that comes to my mind is the folate receptor. So the folate receptor is preferentially expressed on tumors under stress. It is not generally utilized to transport folate into the cell, which is a reduced folate carrier molecule. But is
ubiquitous.
Ubiquitous. But this is unique on ovarian cancer cells, and we want to target it. Another biomarker. So you got homologous recombination defect, BRCA, and now we got the folate.
And it's beautiful because about 80% of epithelial ovarian cancer expresses folate receptor alpha.
Right.
And tends to be overexpressed in higher risk
Right.
tumors. So now you have potentially a target. So how do you target this with an antibody-based approach? Do you create another method? And so there are some very, very creative methods that have been exploited.
And I've heard you talk about this antibody idea, this idea of farletuzumab could bind to folate, antibody-dependent cytotoxicity, complement-dependent cytotoxicity.
Perhaps.
Perhaps. You
Right.
told me it didn't work.
Well, right. So there were 2 important phase 3 trials that examined this antibody approach. So it's just antibody to folate receptor alpha. Mechanism of action, there are some theoretical mechanisms beyond antibody-dependent cytotoxicity. But 2 trials, one in platinum-sensitive recurrent disease and another trial in platinum-resistant recurrent disease, utilizing standard therapy with or without this agent, were both negative, unfortunately.
Well, and I'm reminded of the TDM1 story in breast cancer, where you could have an antibody to HER2 and have a warhead cytotoxic. So that's actually in development, and I think that would be the next step. So the idea was good, but it didn't seem to necessarily translate into a clinical benefit.
And the warhead concept makes a lot of sense. If you can generate folate conjugated to...
Yeah, so it doesn't even have to be an antibody. If it's a folate receptor, do the folate with the... Okay, go ahead.
But the interesting thing is when you have a large molecule that's a conjugate of native folate to a poison,
Mm-hmm.
and the vinca alkaloids tend to be favorites because of the conjugation property and because when given alone in a non-conjugated state are extremely toxic.
Right.
So in low levels, that folate conjugated to drug cannot be internalized through the ubiquitous folate carrier. So it can basically only be internalized into cells bearing folate receptors on their surface, which is a unique aspect of many ovarian cancers and really not seen in any other organ sites other than the renal tubules, where those cells are not undergoing active cell cycling, so less susceptible to cytotoxic agents and probably protected for a number of other reasons. So once internalized and endocytosed into these cells through internal cellular processing in the cells where this is selectively delivered, unleash the cleavage releases the cytotoxic agent, and essentially there's a payload. So the trick is to engineer the best payload, the best type of conjugate into these cells.
And to identify the patient that has a folate receptor.
Correct.
So the company that makes this is called Endocyte. You told me endocytosis.
Endocytosis.
And the agent's called ventafilide. Okay, so there was a study that was just done adding this folate conjugate with PLD called the Precedent Trial. Tell us about that.
Well, this was basically a trial in patients with platinum-resistant disease involving pegylated liposomal doxorubicin plus or minus ventafilide, and it was an open-label trial in unselected patients.
Right.
Now, they had the option of undergoing nuclear imaging with EC20, which is basically folate conjugated to a radioisotope.
Love it.
Beautiful idea. And in fact, 80% of women that entered the trial, as would be expected based on an intent to treat study, is essentially were expressors, had positive scans to various degrees, and 20% of those patients were negative on imaging. The primary endpoint of the trial was progression-free survival. There were about 150 patients entered on the trial and demonstrated a progression-free survival advantage for the combination with a hazard ratio of 0.63.
It's great.
Now, in the EC20 positive group, which was the 80%, the effect size was more dramatic, not by a lot, but it was 0.55.
So this is great.
It suggested that you could actually select.
So this has been a good interview for me because you have taught me that there are biomarkers in ovarian cancer. There is BRCA1 and 2, and there is the folate receptor. And I should test my high-grade serous patients for BRCA1 and 2 mutations, and maybe, once it's approved and more established, do this etarfolatide, which is the name of the EC120 to see if my patient expresses folate and go on this agent.
This is a companion diagnostic, and it's being utilized prospectively in a phase 3 trial now. So,
which is called Proceed.
Correct.
I love it. So here's the take-home message. We have talked about 2 phase 2 programs, Study 19, PARP inhibitor, olaparib, platinum-sensitive maintenance. And we've talked about the Precedent Trial based on the folate receptor. Both of these trials have been submitted to the European Regulatory Agency for conditional approval.
2 different patient populations.
2 different patient populations, but phase 2 studies.
Oh, yes.
So this will be a game changer if we can get conditional approval based on phase 2 trials in ovarian cancer. I really hope we do. And the phase 3 trials, we talked about them, the Solo 2 trial and ultimately the Proceed trial are ongoing. Great stuff.
Really, really an explosion in ovarian cancer therapeutics.
And biomarker driven.
Biomarker driven.
Finally.
Scientific principles being applied.
That's great. Well, Bob, I appreciate you being with us. This has been fun. From San Diego, California, from the first Energy Oncology meeting, this has been Best of the Day. Thank you for joining us.